some people would say in the U.S. that there's no way that I can speed up because I grew up in the South, and in the South we talk really slow. And so, and I'm sure slow is probably good for you guys since you're translating in your head probably what I'm saying. So we'll run through this. I'm going to assume that a lot of you guys know quite a bit about high-frequency ventilation, and I'm just going to kind of review a lot of the literature that's out there and then share with you some common practices in the U.S. In which we even converse ourselves about some of the different practices out there. I will disclose that I do have these relationships with these mechanical ventilation companies. However, I won't be talking about pretty much any of them during this talk itself. So some of the things I want to review for you is kind of the basic principles of high-frequency ventilation. Sometimes we get to using things and we forget about the basics, and that's something that I've kind of made my career off of is going back and reviewing the basics with people because I think they're very, very important. If you can't do the basics, a lot of times you can't understand advanced concepts and things like that. And I've made a textbook out of it, which is one up here I guess I'm supposed to sign in the future. So we'll review high-frequency oscillatory ventilation. I'll review high-frequency jet ventilation, which I'm not sure you actually have here in the U.S., but it's a different form of high-frequency ventilation that we have in the U.S. And then we'll review kind of the literature on both. And then we'll talk about kind of the standard of practice within the U.S. And then happy to converse with you guys about other things. So let's kind of go over the basics about pulmonary injury sequence. So obviously a lot of our patients born prematurely have the absence of surfactant. And so it's kind of known they develop atelectasis, they have this tidal breathing, which can be hurtful, maybe even helpful, but at large distending pressures and those types of things can be harmful. They have this airway stretch and distortion. They develop this cellular debris a lot of times, edema, hyaline membrane formation, and then a lot of times we have to use higher FiO2s to help counteract some of that or keep their oxygen levels high enough. Sometimes we use too high of volumes and pressures, which result in body trauma, barotrauma, and then ultimately PIE, pulmonary interstitial emphysema, and then BPD. And a lot of times that's a direct correlation. Typically, if they develop PIE, they will have BPD. So I forgot to close some of my emails, and so I'm getting emails from here. All right, here we go. So let's talk about some of this, some of these rat lung models that you've probably seen over and over and over again, because a lot of us share them because we think they're pretty important. But really what we want to do is talk about this hysteresis curve a lot of times, is that if we ventilate someone in the lower area, a lot of times we end up doing damage. And so the best way to do that is to increase their lung volume. People have coined this term of optimizing the lung volume to this safe window, if you will. And so obviously, if we're overextending the lung, it can be damaging and it can cause all types of problems. If we ventilate in the area of atelectasis, or the lower lung volumes, then we can also cause just as much damage. And a lot of times in the past, we used to think that overdistension was the only harmful piece, and that atelectatic trauma basically was not a problem. So that's why in practices in the past, you see that lower PEEPs, lower tidal volumes, those types of things were always acceptable versus higher tidal volumes and higher PEEPs and mean airway pressures. But that may not be true. In other words, we really want to try to get into that safe window, if you will. So, but we have to maintain gas exchange a lot of times. And so one of the goals that Dr. Meredith and a lot of these guys that did some of the groundbreaking work with high-frequency ventilation back in the late 80s and early 90s, their goal was to achieve gas exchange but eliminate tidal breathing. And so you think, that's impossible a lot of times. And so but they were able to actually do that. And some of it is, you hear stories about they got these ideas from a panting dog. And the concept is, how does a panting dog actually ventilate? Because they're panting and they're breathing at dead space. And we know that if you breathe at dead space, you don't ventilate. So if I was to take you and give you a 2 per kilo tidal volume, I could ventilate you at 60 times a minute. It still wouldn't ventilate you very well a lot of times. And so they started exploring, how does a dog do that? Because they actually do it to cool themselves down, but they actually maintain gas exchange as well a lot of times. And so if we think about the pulmonary injury sequence, a lot of times we can't prevent the damage a lot of times to maintain our goals. And so when we put someone on the ventilator, a lot of times we end up doing damage. And so we try to minimize that damage as much as possible. And if we use high-frequency ventilation, unfortunately, it does not reverse that injury that has occurred. There's surfactant deficiency and those types of things. And so, but we may be able to interrupt that progression of injury. So, in other words, we may actually be able to save their life in the future by using it. Some of the benefits, ideally, of optimizing lung volume strategies, whether you use high frequency or conventional, is obviously you want homogeneous gas distribution, you want to reduce regional atelectasis, you want to maximize gas exchange and pulmonary blood flow. You want to obviously match VQ, ventilation perfusion a lot of times is what we call it. And then reduction of intrapulmonary shunting, and ultimately reduction in oxygen exposure. So a lot of times if you don't have the lung open, you have to use a much higher FiO2 to maintain that patient's saturations. But if you actually were to open their lung, they become a lot more efficient. So what is high-frequency ventilation? I mentioned that it's these tidal volumes at or less than dead space at a very fast rate. In the U.S., it's defined by the Food and Drug Administration as a rate of greater than 150 breaths per minute. So our conventional ventilators, if you will, are all rated up to 150 breaths per minute, but they can't go over that. Whereas high-frequency ventilators have to have that option of being able to go above it. Our ventilator of choice is for the oscillation is the 3100A. It's a very antiquated, very old device. And our parents think that it's state-of-the-art, and I laugh because it is not state-of-the-art a lot of times. It makes a lot of noise, and they think it's better care a lot of times. And so we'll debate whether it is or not a lot of times. But the mechanisms are the same, and so I'll try to use this picture to describe. We use a baffle here that basically operates at a very high frequency, and it pushes gases forward and back. A lot of the ventilators that we'll play with this afternoon use it on the expiratory side by using what they call a Venturi process. And so they actually push air towards the patient, and then they have a jet that pushes air away from the patient. So they push, pull, push, pull, push, pull. Does that make sense? And so that's how like the SLE and some of the Draeger high-frequency ventilators work, is that they don't use a speaker basically to oscillate. They use jets of gas back and forth at a very rapid rate. And so, but the principles are the same a lot of times, and that's what matters. So when we're optimizing lung volume strategies, and this is a picture of a CT scan of a piglet in which they're increasing the mean airway pressure. And so you can see that if you lay your infants, we were just talking about this morning, if you lay your infants on their backs for the entire time, they get this gravitational atelectasis. So gravity just basically falls and they have these collapses. If you lay them on their left side, guess what? For a long period of time, they will get left side atelectasis as well. And so this is the case in this particular animal that they're doing. And so they're inflating the lung, and you can see here that the anterior sections of the lung are actually ventilating fairly well, and may actually be injurious to those areas, because a lot of times we're dealing with 6 mLs per kilo tidal volumes or something like that, but it's really being delivered all to those anterior sections of the lung. And so in the adult world, they actually developed the baby lung concept, meaning they have a very small lung that you're trying to ventilate. But a lot of times you're trying to use normal tidal volumes to be able to do that, and that can be very injurious. As we increase the mean airway pressure, you can see that we get more lung opening, but you can actually start to see that potentially there's over-distension of these alveoli here. You see that? And so you see these kind of hyperinflated areas, but you still see quite a bit of atelectasis. And that's where we are here. We're just opening the lung to get the lung to be more efficient. When we climb even higher and increase the pressure up here, now we're over-distending even more. But we've got the majority of the lung open a lot of times. And so the problem with this concept is that when you open the lung, like this on the inspiratory limb, as they call it, you have lots of over-distension. So to gain atelectasis, you end up stretching other parts of the lung. And are you doing more damage than good? And that's up for debate a lot of times. Here's another graphical display of this same concept, is that when you're at these lower pressures, you can see here that the lung is completely collapsed. When you increase the pressures, you get to this lung, and then now we're up here to over-distension. But now that we have the lung open, it's easier to keep it open. And so now when we come down on the pressures, we can use less pressure and keep the entire lung open. Does that make sense? And so you can see here now we've opened the lung, so we over-distended it here. And now we're down to 12 of mean airway pressure here, and the lung looks much better than it was even here. Does that make sense? And so it's open and it's staying open. And so that's how we optimize lung volumes. And obviously the benefits of optimizing these lung volumes is that you get enhanced gas exchange to combine gas transport mechanisms. There's hopefully no excessive volume swings because we oscillate in between there. And we hopefully reduce regional overdistension and stretching, and we reduce the term they call volume trauma. So how does high-frequency ventilation work? This is a mode of ventilation that is quite confusing to me, because there's all these principles that you see here of how it works. And we don't know exactly which one is actually occurring within your patient. Does that make sense? And so we know it's probably one of these six, and it may be a combination. In the upper lobes, it may be pendulum. In the lower lobes, it may be talar dispersion. You just don't know a lot of times because, but we know it works. And in some cases, it actually may be bulk flow or convection. So kind of the oscillatory principles is that are different than the jet, for example, or flow interrupters, if you have those types of high-frequency ventilators, is that it actually pushes and pulls gas in and out. And so it doesn't necessarily rely on passive recoil of the lung to actually ventilate that gas exchange. One of the other benefits that we know as well that are different than conventional ventilation is that the transmission of that pressure that you see on the manometer does not reach the alveolus. And so a lot of times you see pressures that are just as high as conventional, but by the time it actually gets to the alveolus that you see here, it is much smaller. And so that delta amplitude drops drastically. And so here's another kind of pictorial of this exact features. A lot of times we measure here proximal at the airway, but if your amplitude is 40, by the time it actually gets to the alveoli, it's much less than that. And so it gives us a reassuring that there's less dispersion of pressure itself. Another thing that we have to think about is some of the knobs, and we'll talk about that in the lab this afternoon, but how to actually look at your power and amplitude and those types of things and get a feel for how the patient's actually transitioning to and from. Our 3100A uses a power control. The more power you give, the harder it pushes, basically. And that creates a delta pressure, and that delta pressure controls tidal volume. And then frequency is quite interesting because a lot of times when we're teaching residents and fellows, they want to think the opposite. You increase frequency, you increase minute ventilation. And with oscillation, you actually do the opposite because tidal volume is square here. And so a lot of times if you go down on the frequency, your tidal volume drastically goes up because your inspiratory time is longer. And then tidal volume is then squared, so its efficiency is actually better. And so it's something that we have to think about quite often when we're manipulating the oscillator, is that going up on frequency a lot of times will decrease or increase your CO2. So let's talk a little bit about that IDE ratio, and this is something that I want to talk a little bit about because I think you guys have the SLE, and some of these IDE ratios are fixed. So I believe the SLE is a 1-to-1 IDE ratio, and whereas the oscillator pretty much defaults in our minds to 33% respiratory time or a 1-to-3 type IDE ratio. We pretty much keep it there. We don't really manipulate that in neonates anymore. And so, and it also concerns me that the SLE does 1-to-1. Just being honest with you is that because we learned back probably in the early 80s about a 1-to-1 IE ratio was associated with higher interventricular hemorrhage. And we were worried that because of the fast rates and the 1-to-1 IE ratio, they were air trapping. And so your mean air pressure was actually being doubled almost in your patient's lungs. And so, so people shied away from that after those initial animal studies because they decided that that 1-to-1 IE ratio was a little bit problematic. And I'm sure the company has a different reason for that, but it's something that I thought was a little bit unusual in that mode of ventilation, and you can't adjust it. Whereas I think all the other ventilators, you actually can adjust this IDE ratio. And so most of us keep it to 1-to-3 and pretty much don't touch it. All right, I'm going to talk a little bit about the jet just to introduce it to you as a different concept. You may not have access to it, but it's a mode of ventilation that delivers these short pulses or jets to the distal proximal end of the ET tube through an adapter. A lot of times that you have to put on the ET tube itself. The tidal volumes, it has functional tidal volumes that are combined with each what they call jet breaths, and so we have like sigh breaths, almost intermittent, sometimes set at a rate of 10, sometimes set at 0. We'll talk a little bit about that. It requires a little bit more passive recoil of the lung than the oscillator does because it actually doesn't actively pull out gas from that itself. And then the baseline pressures such as peak, those types of things are provided by conventional ventilators. And so how does it work? It's somewhere between conventional ventilation and high frequency. There's enhanced diffusion found in the large and medium airways with this altered gas flow velocities. And largely we think the pendulum theory probably tends to equilibrate the gas concentrations in those airways and allows enhanced diffusion. But our understanding, as I mentioned, with even high frequency is a little bit incomplete about how it works. So when you transition someone to high frequency, depending on what mode you use, is we typically transition over to a frequency of 4 to 11 for the jet or 8 to 15. We just actually completed a study that I didn't put in here, but it looks like people are tending to use higher and higher frequencies. So 15, a lot of people are starting on and not going anywhere near 8 anymore. And so it's our belief that we think that the smaller tidal volume are probably better. And so we used to almost set the frequency based on the size of the patient. So a 3-kilo baby would actually get set on 10, for example, in the past. That's no longer that true. In other words, a lot of people are trying to push those frequencies as high as possible because we feel like that delivers the lowest tidal volume. But you do have to worry about some kids that have air trapping disease like meconium aspiration and those types of things. They may need the lower frequencies. And we think that that's why the jet may actually be even beneficial in those dynamic hyperinflation type patients, meconium aspiration, because you can get by with a lower mean air pressure. Then you set the amplitude based on a really scientific term called chest wiggle. And it's something that I am not very proud of that we haven't come up with something better than that, but it actually works. And for the most part, it seems so subjective to me, but most clinicians can actually nail it almost all the time. And so mean air pressure is typically increased above conventional ventilation. Depends on what your strategy is. So if you have PIE or some air leak syndrome, you're going to try to get really close to that conventional ventilation mean air pressure. If you have RDS and with severe lung disease, you may actually climb as much as 2 to 4 in the beginning, maybe even higher once the patient goes on. I mentioned the IDE ratio of 1 to 3. We do 1 to 6 on the jet. And then obviously the FiO2 is adjusted based on the SpO2. This is the chest wiggle factor, as you can see here, and so this is something that we often look at, and so you don't want to see the head moving, you don't want to see the arms flapping, those types of things. You probably have too much if that's occurring, and so it's something that you should think about. I also wanted to mention this, is that a lot of these animations that I share with you are free on openpediatrics.com, and this is something I'll show you, the ventilator simulator as well this afternoon. You can go to resources and download all these. They're absolutely free, and you can use them for teaching purposes. We'd be happy for you too. So also there's two types of lung strategies that are out there, and it depends on the disease. We kind of used to use chest x-rays to drive us a lot, but we've gotten so comfortable with high-frequency ventilation that we now pretty much use FiO2. And so we know that if we have a patient who has air leak syndrome, often we try to use a little bit higher FiO2 strategy and lower mean air pressure. If we have someone who has a very restrictive disease and we were shooting for a high lung volume strategy, then we end up weaning their FiO2 fairly low, even as low as room air a lot of times, and making sure that we maintain their lung volumes by increasing their mean air pressure. So some of the pros and cons, there's less oxygen exposure. I mentioned yesterday about antioxidants, and that's pretty important in our preterm infants, is that they can't counteract a lot of the oxidants that we give them, such as FiO2, and so it's really important to try to get that FiO2 as low as possible. It's a lung recruiting machine, if you will, and so a lot of times it recruits the lung very well and improves DQ mismatch. Hopefully reduces volume trauma, which, remember, we think is probably the number one thing that you should look for, is trying to make sure you keep those tidal volumes as low as possible. And so some of the cons that I've heard and even seen and experienced is that a lot of times you have to have a non-compliant circuit. And that circuit, even though it's better today, is still a little bit stiffer than your typical conventional ventilation circuit. And so it can be a little bit heavy on the ET tube. It can cause the child to have to keep their head to the left and to the right, and so then they get what we call the toaster head a lot of times, because they have to be one side or the other. But we do have positioning aids that we try to use to keep them from getting that. The jet itself requires a conventional ventilator, which is very expensive for us, and so you have a $30,000 machine sitting beside another $30,000 machine, and so that's $60,000 worth of equipment for one child. That's just really, really expensive, whereas the oscillator does not. Some of the current the oscillator that we use struggles at really low mean air pressure, so mean air pressure is at 10, 11, those types of things. It fluctuates and has a hard time maintaining those because it was really designed to be a little bit higher than that. I call it a stupid ventilator, no disrespect to the manufacturer, but I teach residents and fellows that you can go up to the ET tube and you can clamp it, and the ventilator does not alarm, nothing happens, because it's happy delivering the pressure that it's given. It doesn't monitor tidal volume or anything like that, and so you have to make sure that you understand when you're troubleshooting. So you walk to a bedside or you get called to the bedside because their saturations are low or they're bradycardic, you got to look at their chest wiggle. If their chest is not wiggling, I don't care what the ventilator tells me, they're not ventilating. And so you need to treat that appropriately. But I wish the ventilator would give us a little bit more of a heads up that things are going south and not doing so well. In our country, there's no competition for high frequency ventilation, and so that to me has stifled creativity. I know in Europe, and I don't know about here, but in Europe there's at least 4 to 5 high frequency manufacturers, and they all compete against each other, which I think competition is good, frankly, because it makes people make better products to try to sell them. And unfortunately in the U.S., we only have one, and it's the oldest probably form of high-frequency ventilation out there. So let's talk about the literature a little bit as I wrap up. Is that I want to know, is high-frequency better often? And this was something that I remember in 2002 when this was published in the New England Journal. I was heartbroken because I really believed back then that high-frequency was a superior mode of ventilation. I thought everybody should go on it. and those types of things. And then this study came out talking about the prevention of chronic lung disease. So using the oscillator proactively, and unfortunately they found that their results did not significantly differ from conventional ventilation. So using it proactively, they felt like it didn't help. And I alluded to a little bit of this yesterday because Sherry Courtney came out with another study that was published in the New England Journal that showed a small but significant benefit of high-frequency oscillatory ventilation in pulmonary outcomes, meaning BPD and those types of things, for the very low birth weight. So she had a cohort of patients that were even smaller, and they actually benefited from high-frequency ventilation. And you kind of wonder, why would that be? Why would you have two different outcomes? And so she found a very special patient population in which it actually was very effective for. The other thing is that Natalie alluded to is that, if you're good at something, Sherry Courtney's group is actually wonderful at high-frequency ventilation. They do it all the time. And there's some benefits that I think the child receives from being on high-frequency ventilation. And something that we now do routinely, but like bundling, leaving the child alone, not messing with them all the time. And so when you go on high-frequency ventilation, you actually get kind of special attention in 2002 or before, is that it was a newer form of ventilation. Everybody was very careful. They looked at it. They maintained it appropriately. So they bundled these guys. They kind of draped their isolette, and they left them alone to grow and do all types of things. And so you wonder if some of that benefits is kind of the Hawthorne effect of actually looking at them, monitoring them even closer, and making sure that their protocol was being followed exactly. Because variabilities in protocols can actually have variabilities in outcomes. Some of the studies, or some of the findings that she shared with us through her study, is that the mean air pressure, not surprisingly, was higher than conventional ventilation. And so some people were scared that mean air pressure would lead to more interventricular hemorrhage and those types of things, and she did not prove that helpful or hurtful, for mean air pressure. So what about the elective use of high-frequency ventilation? And so I told you I go to these Cochrane reviews often when it comes to meta-analysis, those types of things, is that should I use it proactively like Sherry Courtney's group does? And when they looked at this meta-analysis, they could not conclude that that would actually be helpful to use it over conventional ventilation for first-line strategies. So what about high-frequency versus conventional when it comes to chronic lung disease? And again, it looks like it's leaning towards favoring the high-frequency ventilator when it comes to chronic lung disease. But one of the things I want to draw your attention to is look at the age of these studies, 92, those types of things. That's a little bit concerning because in 92 we weren't necessarily doing the surfactant replacement therapy the way we do it today. And so I wonder if they're actually equivocal when it comes to looking at these studies. We also didn't do prenatal steroids as well as we do today a lot of times with this type of study. And so you wonder if you're comparing really apples to apples, if you will, or is it really apples to oranges to nowadays? And so you have to think about these studies a little bit when they're that old to try to find outcomes. What about high frequency versus conventional in infants with severe pulmonary dysfunction? And this is where there's actually some evidence that shows that it may be actually beneficial. And so those patients who develop severe RDS and the oscillator as rescue therapy may be actually beneficial. And so it's not conclusive, but it's leaning certainly towards that direction. What about high frequency versus conventional in this term or near-term infants who failed conventional ventilation? And so again, severe lung disease, they failed this therapy. Will they likely respond to high frequency? And the answer looks like it's leaning towards yes. And so again, in severe disease, preterm and term or near term. High frequency versus conventional in term or near term for intracranial hemorrhage. And so it looks like these patients, it actually favors high frequency, that they'll have less interventricular hemorrhages. And so remember, initially when we were using these higher mean air pressures and those types of things, people were worried that they would actually have more interventricular hemorrhages. High-frequency jet ventilation now. I'm switching gears on you a little bit to a little bit different mode of ventilation. Improves gas exchange in extremely immature infants with evolving chronic lung disease. And I heard from some of you guys yesterday that BPD, or chronic lung disease, is a big patient population of yours in which you're having to use high frequency to help either rescue them or maintain them. The high-frequency jet may actually be beneficial in this patient population as well. And we'll talk a little bit more about that strategy and what we use it for in the U.S. Often. But some of the results that Marty Kessler's group shared with us is that certainly the 1 to 3 hours before high-frequency jet, the CO2 is here, the oxygen index is here, and so an oxygen index of 11, which is a pretty significant oxygen index. After the first hour, it really doesn't change much, but after a day of this therapy, it actually reduces quite drastically, and you see the CO2 comes down as well. And then before extubation, basically things are looking really, really good for patients who are on the high-frequency jet ventilator. How about rescue from high-frequency jet ventilation versus conventional and severe pulmonary dysfunction? Unfortunately, there was only one study that actually favored conventional. So we have conflicting results here. Unfortunately, that met the meta-analysis criteria to review. And says conventional is probably just as good in this patient population when it comes to mortality. When you compare the jet to conventional in preterm infants with chronic lung disease, it looks like it favors the jet. And so the jet is seeming like it has a special patient population in which it's probably beneficial for and may work really well for. So kind of the standard of practice in the U.S. is that many of us use high frequency or jet for rescue therapy. I think there's hands down that most people use it this way. I think some people do use it proactively. In other words, they use it if you're born less than 750 grams and you require intubation, they may actually proactively put you on high frequency and just start there. I don't think that's a bad strategy. I just think it's a different strategy, and there's not a lot of evidence that says that one's superior to the other. I'd like to see those studies redone nowadays when we have careful vital volume monitoring and our strategies of not intubating and those types of things may be different, or the outcomes may be different. It appears that many in the U.S. have both high frequency and jet. And it seems like people use the jet for air leak syndrome or this dynamic hyperinflation. So you get these kids that have bronchopulmonary dysplasia and are extremely hyperinflated, but can't oxygenate, can't ventilate very well because the jet, remember, uses a much lower frequency. You typically can get by with a lower mean airway pressure than the oscillator. A lot of times the oscillator requires a higher lung volume and a higher mean airway pressure to actually effectively ventilate these patients. And so we use the jet for air leak syndrome in our NICU, and then in our cardiac ICU we use it for patients that are having problems ventilating or oxygenating who have cardiac disease in which they can't tolerate a higher mean airway pressure, but they need significant support because they have large amounts of dead space ventilation going on. And so kind of in conclusion of high frequency in the neonate, there's little evidence that it's better than conventional. And so that's something that we have to think through. I think it's probably helpful in severe lung disease as rescue therapy. It remains popular, and sometimes I'm not sure why. And I don't know if you follow ventilation literature, but the adults have tried high frequency out in adult ARDS and have found that it's actually not that beneficial, and it may actually increase mortality. And so that's been all over the New England Journal recently about it, and it's confused us because in neonates we feel like we have significant evidence that it's probably not, at least not harmful, and may be beneficial, but they're actually showing harm in adult patient populations. And so unfortunately our technology is stagnant, and that's something that I think is also driving some of our concerns. It certainly doesn't hurt and may help. And then last but not least is one that I think may make the difference in the future is allowing patients to spontaneously breathe on high frequency. I think that's why it's probably more beneficial in our smaller infants than it is in our adults, because in adults or even older pediatric patients, you can't allow them to spontaneously breathe on our 3100A or B oscillator because it's a fixed flow rate system. And so if they start to breathe, they actually change the mean airway pressure, they change the whole dynamics of the ventilator, and it's really difficult. Whereas our preterm infants, they can actually spontaneously breathe on that bias flow very easily, and that way we have to use less sedation, certainly no paralytics, and I think that may make the difference between the outcomes. I'll be happy to take any questions that you guys may have.
You see here that we are going now for high frequencies, either infants or neonates. Whether in full-term infants, we used to use lower frequencies, like 10 or 11, and preterm we used high frequencies, 14, 15. Now this means that we ventilate both preterm and terms by high frequency, 15 hertz or 14 hertz. No difference?
No difference. A lot of times we may still start at that 10 or 11, but one of the ways that we actually will increase their CO2 if we're over-ventilating them is not by adjusting the amplitude, but going up on hertz a lot of times. And so there's some animal data that I didn't share with you that actually looks like it actually is lung protective. So they created air leak syndrome in these animals and showed that they could reduce the amount of air leak at higher frequencies and higher amplitude. So remember, when you go up on the frequencies, if you're trying to maintain your minute ventilation, a lot of times you have to keep that amplitude up. You can't lower that and increase your hertz because your CO2 will go through the roof. And so, but we have kind of implemented that for almost everybody. This is what we call a high hertz strategy, which is something that we think is probably beneficial. I don't have conclusive evidence that it is, but it is something that we've implemented in our institution.
Okay, you can start both for high frequency and manipulate according to the parameters and the.
Yes. Yeah. You're welcome.
Thank you for your elegant presentation. I just want to ask, how do you adjust the IQ in high frequency?
So we don't, and so we leave it at 1 to 3 or 33% a lot of times. And so we used to. I will tell you that I have some pediatric experience, and we used to manipulate it in the older pediatric patient population just to try to get the tidal volume up, so that we could actually ventilate them because we had problems with CO2 elimination. But that was more of a device problem because we were using an infant oscillator in older patients that it wasn't designed for. And so now we have a 3100B, which is an adult or a pediatric adult high-frequency ventilator, and we don't typically manipulate IDE ratio anymore. Yeah. No, I would say set it and forget it. And that's another thing that I failed to mention, that one of the reasons I think that high frequency actually may be more beneficial is that there are a few knobs that you have to manipulate, and they're kind of independent. So if you think about, I use what they call the KISS philosophy, is keep it simple, stupid. Mean air pressure and FiO2 to control oxygenation, amplitude to control CO2. And it's pretty simple. Whereas with conventional ventilation, you have all these other parameters that you often have to change. So.
Any more questions?
Thank you.